This is the third talk in the pain series. I'm going to go in the foundations of various kinds of pains so that when we are looking at the drugs and various interventions, we understand what do these interventions do. Welcome, everyone. This is the third talk in the pain series. The idea was to cover the topics for Drug Enforcement Agency's pain series requirement. However, I'm going to also go in the foundations of various kinds of pains. What are the mechanisms of those pains so that when we are looking at the drugs and various interventions, we understand what do these interventions do. So with this, let's start. I'm going to share my screen. This is an important reference that I'll be using. I try to find references that you can access online as well. These two are the basic foundations for our discussion today. In addition to that, there are some more references which I would link afterwards. For example, erythromelalgias, then chronic pain and epidemiology of that, then the neurological pain, classification of neurons, neuron types, etc. What is the nervous system? So we'll talk about all of those things today, but here are the references as well. And I wanted to share this beforehand. This has happened more recently because of the COVID events and COVID-related intervention events, that the complex regional pain syndromes have become very common. Complex regional pain syndromes are pains that start in the body and are not explained. And actually, we do not even know the pathophysiology of those pains. So, for example, if you see here, this is Mayo Clinic. Complex regional pain syndrome is a form of chronic pain that usually affects an arm or a leg. Complex regional pain syndrome typically develops after an injury, a surgery, a stroke, or a heart attack. The pain is out of proportion. So, although COVID-related or vaccine injury-related, however rare the injury may be, that usually affects the whole body. But if you see the symptom set, you would see that this regional pain and that systemic pain are kind of overlapping symptoms. For example, continuous burning or throbbing pain, usually in the arm, leg, hand, or foot, sensitivity to touch or cold, swelling of the painful area, changes in skin temperature, changes in skin color, ranging from white and blotchy to red or blue, changes in skin texture, which may become tender, thin, or shiny, changes in hair and nail growth, joint stiffness, swelling, damage, muscle spasms, tremors, weakness, decreased ability to move the affected body parts. So you might actually see this cluster of symptoms, not just regionally, but in more broader areas of the body as well. So with this, let's start with my drawing. So the objectives for today's discussion are the following. Number one, we are going to review the structural components involved in neuropathic pain, not just pain. So keep in mind that neuropathic pain will include any part of somatosensory tissues of the brain or of the nervous system and any lesion of the somatosensory system. And I'll explain what that system is. We'll look at neurons, but with a new eye. This is not neuron has an axon and a dendrite and a body, and there we go. This will be looking at sensory neurons, for example, to understand why they are so affected by pain or why they are so vulnerable to, for example, inflammatory molecules causing malfunction of these neurons and causing pain. Then we'll look at the nociceptors as well. We have actually done that discussion last time and the time before, but still nociceptors will be interesting too. Then we'll look at what are spinal nerves and peripheral nerves, what are sensory nerves, motor nerves, autonomic nerves, and finally the definition of neuropathic pain and the history and the research. There are some very important clinical points that you would come across as well. So let's start. So this is the understanding of a sensory nerve, especially from a context of nerve lesion. So sensory nerves, not just the pain nerves. Sensory nerves, of course, for example, touch, pain, pressure, temperature, deep touch, vibration, two-point discrimination, proprioception. These sensory nerves originate from various parts of our body. From a sensations point of view, all the sensory systems can be categorized in two bigger blocks: visceral and somatic. Somatic are those parts of our body that are under our control. We cannot flex bones like we do with the muscles, but we can still move bones. So bones, muscles, tendons, these are all somatic parts of our body. Visceral parts are the organs and the tissues. So here we are talking about the somatic sensory system. The unique thing that I want us to focus on, first of all, is the following. The neurons, the sensory neurons, are present, their body or soma is present in the dorsal root ganglion. These cell bodies are present outside of the nervous system. As the nerve enters the spinal cord, just before entering the spinal cord, there is a swelling in the nerve, sensory nerve, which is a collection of cell bodies of the neurons, and that collection is called ganglion. Interestingly, the sensory nerves, apparently, it looks like, if you look at it under a microscope, it looks like there is a continuous thread which is going from some part of our body, that may be skin, that may be muscle, that may be bone, that may be some other sensation from other parts of the body. And it seems like it is continuously going towards the spinal cord, and there is just one swelling on the way. In reality, if you follow this red thread over here, this thread continues and goes into the neuron cell body, and then it comes out as well, or we simply describe it as there is a T-shaped bifurcation. There's a T-shaped bifurcation here where one thread actually becomes divided into two. Then if you follow these threads from here, from this center where the cell body is, then one of them goes to periphery and gets attached or innervates, as we say, some part of our body, and the other one goes towards the center. Because of that, now this is very important for the definition, this whole thread is actually called axon, and this part that goes and connects with various parts of our body is called peripheral part of this axon, and the one that goes into the spinal cord or brainstem areas, or let's say central nervous system, brain, brainstem, and the spinal cord collectively are called central nervous system. So that part that enters the central nervous system is called central process. You will actually see some literature that says that this part here that goes, which is the peripheral part, is a dendroid, and this part, the central part, is an axon. You would actually see some literature that says there is one axon and then there is another axon, but most literature would mention this to be one axon that has been divided into two parts at the ganglion or at the soma. Now, because we're talking about sensory nerves, there are going to be myelinated nerves, fast myelinated fibers, and there can be slow, small in diameter, unmyelinated fibers. For me, I have just made the myelinated fibers here and assume that there are unmyelinated small diameter fibers too. What I want to discuss here is the following. This one concept that I'm going to present is the most important part of this whole discussion. So once you have captured that, then we're good. That is this. In the dorsal root ganglion, this is sensory nerve bodies. There are, of course, hundreds and thousands of nerve bodies that are present here. These nerve bodies, number one, they can release glutamate. What that glutamate does is that they can, so let's say this is a nerve cell body, it can release glutamate that would affect the central process. That will affect the central process. And it can facilitate it, or it can help modulate the impulses that are going through this. Now, please also remember, the nerve impulses that are going in this nerve do not actually end up in the soma and then take their route towards the center side, which is the normal thing. If I have another neuron over here, neuron, this is cell body, this is axon, there are dendroids on this side, the impulse will travel from here to the soma, then from soma to various dendroids. That is not the case in sensory nerves. The impulse actually travels through this axon directly from the periphery to the center, and the nerve cell body that is sitting here can modulate it. It can send various kind of neurotransmitters and affect the ongoing stream of impulses. Secondly, this is also very important, that within this dorsal root ganglion, where there are hundreds and thousands of neuron cell bodies, they can release GABA, gamma aminobutyric acid. They can release GABA and they can actually influence each other. So this is the communication happening between the neuron cell bodies within the dorsal root ganglion. And with this GABA, they can actually inhibit each other and they can gate various kind of pains. This is why, especially when there is pain that is passing through our body or passing through these nerves, If there is another kind of sensory input also passing from this area, so let's say I have pain in my hand and then I touch my hand. So now from my hand area or wherever I'm touching, and if there is pain too, there are two kinds of sensations that are going. One is a pain sensation and the other one is touch sensation. Now, touch sensation has a faster route. So what happens is faster fibers can cause their neurons to release GABA and gate the slower fibers. This is why pain can be abolished or reduced in intensity if at the area of pain there is some other sensation produced as well. This is a very important concept to keep in mind. So here, the clinical takeaway is that within the dorsal root ganglion, there is a possibility of release of glutamate and or GABA. GABA would act as a gating mechanism. Glutamate would act as a excitatory or modulatory mechanism. Why is this important? When we will talk about various kind of pain management interventions, at that time, GABA will be an important thing to keep in mind. So please remember, in the dorsal root ganglion, GABA acts as a gating mechanism. Now, another really important mechanism. In the dorsal root ganglion, again, this is a little swelling in the just before the nerve that comes out of the spinal cord. And this swelling is present. These are the cell bodies of sensory nerves that are passing from here. In the dorsal root ganglion, the neuron cell bodies that are present, we call them soma, sensory neuronal somas that are present here. These are covered by special glial cells. Just like the axon itself can be covered by Schwann cells, the cell bodies are covered by glial cells. So imagine if we are the neuron and our face is a cell body, then if we cover that with a hat or something, that is a glial cell. What is the importance of these glial cells? Couple of things that are really important. Number one, these glial cells, the latest research shows they have a potency to make more glial cells, and they can also make more sensory neurons. They're called bipotent, meaning they can make two kinds of cells. They can make more glial cells and they can make more sensory cells. So when sensory cells are damaged, these glial cells can actually give rise to new sensory cell. So there is a possibility of sensory neurogenesis in our bodies. At least the animal studies have shown that this happens. So that is one important factor. That means neuroplasticity is very important. Second important thing, and I think this would be really important, these glial cells do not cover the neuron cell bodies completely. They do not cover them completely. They leave gaps between them. Those gaps allow macromolecules, for example, various electrolytes and, for example, other molecules present in the blood. Those allow the macromolecules, especially inflammatory molecules, to come in contact with the nerve cell body. Does not happen or should not happen in the brain or in the central nervous system. Ideally, these are nerve cell bodies as well. They deserve the same protection as well. However, they are not afforded the same protection. These nerve cell bodies are covered for protection. Let's say this is kind of a rudimentary blood-brain barrier. Of course, it's not brain. This is a peripheral neuron. But let's use that term for a second. Let's say it's a rudimentary blood-brain barrier. This is not a very good barrier because the cells are separated from each other, leaving gaps. So that means if there is anything in the blood, any inflammatory molecule present in the blood, they would have an access to these neurons. That means it is possible that people who have inflammation in their body, they may have pains and sensory issues, paraesthesias, while their central nervous system will be intact. And so one could start wondering as a physician that why are the peripheral nerves getting damaged and the central system is working okay? And then one of the reasons, there can be many factors, one of the reasons is that neuroglia have a gap between them from where various molecules present in the blood can connect and penetrate these and go to connect with soma. So then you might say over here that this is still not too bad, because the blood vessels normally that come in contact with the neuronal tissue, those blood vessels have a continuous endothelium. They have a continuous wall. They are careful not to release things. That is what happens in the blood-brain barrier. The blood vessels are kind of closed off. They cannot just spill things into the nervous tissue. But if I go to the next diagram, blood vessels in the dorsal root ganglion, they are a combination. Their walls, think about a hose in your mind. That hose has a wall that is continuous. But imagine that that hose has some areas where there are holes in it. We call it medically, we call it fenestration. So there are some continuous part of the blood vessel, and then there are some part that has holes in it, fenestration in it. These holes, these fenestrations allow molecules from the blood to spill out, to come out of the blood vessels. And now, because we know that the glial cells are leaving gaps in there as well, then what will happen is various neurotransmitters, various macromolecules, various drugs, they would simply come out of the blood vessel in the dorsal root ganglion. They would pass between the glial cells and they would go and affect the neuronal cell body. That effect could be useful and that effect could be harmful. So this is, we're talking about all peripheral nerves, although there is a difference between peripheral nerves definition and cranial nerve, but cranial nerves are also peripheral nervous system's part. They also have similar behavior. The only thing is, those cranial nerves whose ganglions or whose nuclei are present within the brain stem, they will not have this issue because they're covered by the blood-brain barrier, which is covering the brain stem, and the spinal cord. So where does endothelial dysfunction fit here? So here, not just the endothelial dysfunction, endothelial function, normal function also allows inflammatory molecules to reach the dorsal root ganglion. That means someone who may have inflammation for whatever reason, those inflammatory molecules can penetrate, come out of the blood vessels, and then go between the glial cells and affect the neurons. Now, if there is endothelial dysfunction, that is an altogether different kind of a pathophysiology, depends what kind of a dysfunction we are talking about. If the dysfunction is inflammation of the endothelium, then we are more looking at the clotting that is happening within the blood vessel, because the dysfunction would cause local inflammation, which will cause local clot formations, which will cause onward blood circulation issues. And whatever is the tissue, that tissue is going to start getting harmed. So if that is happening here within the dorsal root ganglion, let's say that this blood vessel or the blood vessels here have endothelial dysfunction, which has caused the endothelium to kind of swell up with inflammation, plus local inflammation within the blood vessel is causing the clotting or microthrombi to develop, then this mechanism will cause a problem with the blood supply to the dorsal root ganglion as well. And so will it do for other tissues too. When the dorsal root ganglions can be affected so simply and so easily, not only sensory paresthesias will be seen, but pain will be seen as well. And as I discussed in the last lecture, that when a sensory system is firing incorrectly, so ideally the firing should occur here on the peripheral part where the receptors are. From there, the firing would occur and the impulse would go towards the brain. However, if the firing starts occurring, let's say over here, let's say the soma is under stress because of inflammatory molecule and it is causing incorrect function, that may cause the impulses to generate from here, which will be called ectopic impulses. And these impulses can then travel towards the periphery as much as they would travel towards the central side. Now, when these will travel towards the center, then whatever is the kind of nerve, that is the kind of feeling we will have. If it is a touch nerve, we'll feel touch. If it is a pain nerve, we'll feel pain. But the impulse that has gone to the periphery, that can cause the peripheral receptors to release CGRP and substance P. Not all receptors do it, but for example, free nerve endings of pain, they do that. And when they release CGRP and substance P, that would cause whatever tissue is in question connected to that nerve, that tissue might become swollen, red, and painful, while there is actually no problem here at the tissue level. So let's, for an example, say this is connected to a toe or the skin of the toe, this nerve. So the toe is fine. However, because the nerve over here, the nerve ending over here, is receiving signals from this ectopic stimulus, they would be releasing CGRP and substance P over here, which would cause local inflammation, and the patient would feel and actually have the experience, physical experience of local damage. For example, they would have swelling there, they would have redness there, they would have the feeling of pain from there, although there is no reason to have damage over there. So that is what we discussed last time as well. Now, I want to clarify here that ectopic impulses, ectopic simply means somewhere else from where it should be. Ectopic impulses can occur not just because of the inflammatory molecules coming out of the blood vessels, penetrating between the glial cells and affecting the soma, but that can be if there is a nerve compression, if there is a direct attack of the immune system on the nerve, if there is a myelin sheath damage of the nerve, and many other possibilities. Complement deposition, antibody deposition, drugs or toxic substances that attacking this area. So ectopic stimuli can occur because of many reasons. Simple compression can do it. Simple mechanical crushing can do it, or mechanical intervention can do that. Surgeries can actually render nerves in an uncertain state. And I'll talk about that a little later. So I want to back up for a second, and I'm going to request you to kind of have these two concepts solidified in your mind, that dorsal root ganglion do not have the protection as blood-brain barrier provides protection to central nervous system neurons. Because of this, sensory system is more at stake of becoming affected by toxins, by drugs, by neurotransmitters, and by inflammatory molecules. This is why, as a provider, as a physician, as a person who's taking care of others, or someone who's taking care of yourself, this should not be always a wonder that why is the central nervous system behaving okay and the peripheral nervous system is not. This is one kind of a reason that can do it. Okay, so with this, let's continue. I want to read this. This is the clinical importance of the above two mechanisms. So I'm going to read from here. Similarly, by a mixture of continuous and fenestrated endothelium, so some continuous, some fenestrated, meaning having holes in it, that also allow extravasation of dye tracers and macromolecules. As a consequence, unlike central nervous system, neurons that sit within the blood-brain barrier, central nervous system, brain, brainstem, spinal cord, these are the neurons that sit within the blood-brain barrier. Unlike them, sensory neuron cell bodies lack a barrier to the circulation. Does this make clear that why some people who have inflammatory state going on have pains and sensory paresthesias? And I hope I have conveyed this and it has become clear that when this will happen, these influences may act to produce ectopic stimuli, because I mentioned earlier that the soma, the cell body, is able to release various neuronal or neurotransmitters to modulate the impulses. And when they themselves are under stress, they could actually cause enough instability with the connected axons that the impulse would start generating from here, which will then travel to periphery as well as to the center. And the peripheral part can cause symptoms on the peripheral area where there is actually nothing wrong. But even then, the patient would have swelling there, they would have pain there, they would have redness there, and an actual inflammation would occur there. Why? Because when substance P is released, or when the CGRP is released, they actually activate the local immune system over there to cause a cascading activation of the immune system. So I hope these three concepts are crystal clear. So back here, as a consequence, unlike central nervous system neurons that sit within the blood-brain barrier, sensory neuron cell bodies lack a barrier to the circulation. These structural features make it likely that sensory neurons are readily exposed to inflammatory mediators, systemic drugs, or toxins present in the systemic circulation, perhaps more so than many other organs in the body. They are even less privileged than other organs in the body. And again, my commentary, this may actually be by design to give us a quick alert to say something wrong is happening in the body. Okay, so this is just another depiction that the brain or the central nervous system is sitting within the blood-brain barrier, and so the blood doesn't really affect it, but the dorsal root ganglion neurons are actually washed. by some of the molecules present in the blood. Okay, so let me explain my theory. Again, this is a CME talk, and my theory is dismissible, right? I could be wrong in this one. So think about it for a second. Central nervous system is protected by blood-brain barrier. So the macromolecules, that means big molecules in the blood, macromolecules, toxins, drugs, neurotransmitters do not have that freedom of coming out of blood vessels and getting into the brain. This can happen when the whole blood-brain barrier itself is inflamed. When the endothelial dysfunction has caused the blood-brain barrier to open up as well, then all bets are off, because now the central nervous system will also have molecules spilling into it from inflamed and opened blood vessels. But let's say that the blood vessels of the blood-brain barrier aren't in that state, because they are actually very close and tightly closed, and whatever is moved out of them is actually moved out not by spilling things out, but through channels. So very tightly controlled system. The dorsal root ganglion, where sense of pain is traveling from, temperature is traveling from, deep touch, pressure, 2-point discrimination, vibration, all of those senses are passing through this area, this dorsal root ganglion. That ganglion has, as we just discussed, fenestrated blood vessels and the glial cells that have gaps between them. So it looks like by design, this system is put together this way, or has evolved this way, whichever way you believe, which allows the factors inside the blood to affect the peripheral nerve, which my theory is that it is probably a sensory system for us, that when there is some poison, toxin, inflammatory molecule present in the body, and it is dangerous enough that it goes and affects the soma, then the whole body of ours will light up with paresthesias and pains. And that may be a sensory system and alert for us. Because other tissues in our body, not just the central nervous system, other tissues, our liver and other, they actually have better protection than the dorsal root ganglion. Okay, so I hope that this is clear. We have seen the clinical importance as well. And just very quickly to show you where it is, this is the article, Functional Anatomy of Sensory Nervous System, Updates from Neuroscience Bench. This is the publication, September 25, 2019, so pretty recent. In that publication, as you look at an overview of peripheral sensory neuroanatomy, these things are written here. So meaning I'm not just making up, other than the part that I made up, I have already said that is my thinking. Okay, so continuing. Now very quickly, what are these nerves? So a few nerves terms that we'll talk again and again as we look at the neuropathic pains. Spinal nerve versus peripheral nerve versus sensory nerve, motor nerve, autonomic nerve. There are, of course, visceral, etc. There are cranial nerves and there are special sensory systems. I'm going to leave them generally. A spinal nerve is a nerve that is composed of various sensory neurons that are entering a specific segment or exiting a specific segment of the spinal cord. So let's say this is some segment. Let's call it lumbar 1. I'm just making up. So those who know medicine, don't start looking at this diagram and say it doesn't look like lumbar 1. So let's just assume it is lumbar 1. If it is lumbar 1, here is this red is the sensory neuron going into the spinal cord. The blue is the motor neuron coming out of the spinal cord. And well, we shouldn't have the sympathetic system down there, but let's say there is a sympathetic fiber here as well, the ganglionic chain and the sympathetic fiber too. So make it somewhere above, let's say thoracic 7, just so that we can accommodate the sympathetic system too. So all of these nerves together form a bundle when they come out to the spinal cord. These together are called mixed nerves. They make a mixed nerve because there's sensory nerve in it, there is motor nerve in it, there is sympathetic fibers in it, and this is called a spinal nerve. Spinal nerves then give off branches. Then some of those branches would mix with each other and recombine with each other and then make peripheral nerves, for example, sciatic nerve or femoral nerve, etc. So that is the difference in spinal nerve and the peripheral nerve. And of course, the sensory nerves are the nerves that are bringing in sensations. Motor nerves are the ones that are bringing in messages to the muscle, and sympathetic or autonomic nerves are the ones that are bringing in sympathetic system. There are, of course, parasympathetic nerves too. I have altogether left the visceral nerves out and cranial nerves out. So just wanted to make sure that we can see the definitions. Now, definition of neuropathic pain. With all of this foundation under our belt, what is neuropathic pain? I want to read to you the previous definition and then updated definition. Previous definition was pain initiated or caused by a primary lesion, dysfunction, or transitory perturbation of the peripheral or central nervous system. So pain that is initiated by a primary lesion, so direct injury to some nerve or some nervous system tissue, dysfunction of some nerve or nervous system tissue, or transitory perturbation, a temporary, dysfunction or disturbance of a peripheral or central nervous system. This was previous definition. The latest definition of neuropathic pain is pain caused by a lesion or disease of the somatosensory nervous system. Done. Somatosensory nervous system is soma is our body, sensory system is sensory system. Somatosensory nervous system is the nervous system that is able to control our body voluntarily and that is able to bring somatic sensations back to us. Somatic sensations being pain, temperature, touch, deep touch, pressure, vibration, proprioception, 2-point discrimination. All of those senses are called somatic senses. There are visceral senses as well. There are special senses as well. I'm not talking about them, but they are part of the sensory system. And then the soma, for example, if I'm moving my hands or arms, that is the motor activity going towards my body and I'm able to control it. Any lesion in this system is neuropathic pain, or any pain because of the lesion or disease of this system will be called neuropathic pain. So is there any tissue that should not, of our nervous system, that doesn't participate in this part? Yes, for example, cerebellum, as they give an example here as well. Cerebellum does not directly work with the soma or sensory system. It does do modulations and it does help with the planning and execution of the movements, but it doesn't directly work with the somatic or sensory system. So cerebellar lesions and any pain because of that is actually not called neuropathic pain. Although over here they say maybe this definition will be updated again and cerebellar-like lesions will be involved as well. The other kind of pain that they exclude because of this definition is, for example, the chronic regional pain syndrome type 1. So as I said right in the beginning of the talk, regional pain syndromes are the pain in various body parts, usually limbs, after accidents or surgeries or fractures or other such issues. And so the patient has a problem with one arm, for example, and they have pain over there and they have burning sensation and they have itching and the redness of the skin and the blotting of the skin, as we saw all those symptoms before. This is called a chronic regional pain syndrome. With the recent events, with the recent COVID pandemic, we could see the symptoms of this CRSP to be actually more systemic in some patients as well. But anyways, because for the CRPS, I am saying SP, for the CRPS, no exact location or area or the tissue damage is known, this syndrome is excluded from neuropathic pain. So, for example, the new definition means that a condition like chronic regional pain syndrome type 1 is not considered a neuropathic pain syndrome because the affected somatosensory system is intact. So, this is the definition. Definition is pain caused by a lesion or disease of the somatosensory nervous system. Now, I want to go to the next part and present to you a little bit of a history for how the research about pain started. The benefit of seeing that history is that it would actually consolidate in our mind many of the pain-related concepts that are actually elusive to many of us because we don't go in the pain management specialty. So I think you will like this history. So again, here, Journal of the American, this is the American Physiological Society. This is their article. It's a beautiful article. And I'm going to go a little with the history here. So pain following injury to the nervous system has been known under different headings such as nerve injury pain, neuralgia, deafferentation pain, neurogenic pain, and central pain. We're talking hundreds of years ago. So during this time, various names have been given. However, in most instances, and now also recognized by IASP, IASP is International Association for Study of Pain. The term neuropathic pain is used to avoid any postulated mechanism or a specific anatomical location of the lesion. So nowadays, when we say neuropathic pain, we try to avoid the lesion's area or a specific tissue. So the history is 100 to 150 years old, but I want to share some parts of this. So Silas Weir-Mitchell, considered the father of neurology in the US. So what he did was he was treating patients of the Civil War, and he was observing their injuries and what is going on with their neurological systems. So he says, heightened sensibility, or that state in which agents usually felt as touch only become painful, is sufficiently common after many forms of injury. So what he's saying is that sometimes when you just touch some part which should be felt as touch, he said in many forms of neuropathic injury, or whatever was said those days as the name of this, he said the touch or other senses are now converted to pain. We now call it allodynia, where a sense that should not create pain is creating pain. And I always give this example. Imagine somebody has a first-degree burn, and if you touch them where the burn is, that simple touch would cause pain. And if you touch some other part of their body, that would just be touch. So this is allodynia. So Mitchell was talking about it hundreds of years ago, 1872. This description by Mitchell in 1872 is probably the first example of allodynia. Then he says, I have never been able to discover that the tactile sense, the sense of touch, had been thus overexcited so that Weber's points could be distinguished as two. Weber's points are, so when we do two-point discrimination is that you bring two needles or two small toothpicks or something like that, or wools, very close to each other and touch the patient. And you ask the patient to keep their eyes closed and say, are these two touches or one? These points are called Weber's point. And if the patient can tell that these are two, when in fact these were two, then that is called two-point discrimination. And if the patient cannot tell these are two when they were two, then we have a problem with the patient's, or it could be physiological as well, but this could be a problem too. We have a very high sensitivity on our fingers, on our nose, lips, and some other parts of the body. We have very less sensitivity on the skin of our back. So he's saying, I've never been able to discover that the tactile sense had been thus overexcited so that Weber's points could be distinguished as two, where otherwise they could have been felt as one. When indeed there is hyperesthesia for pain, we are apt to find it associated with lessened or lost power of tactile appreciation. So in general, what he's saying is, when there is pain from some part of our body, then this hyperesthesia of pain, we are apt to find it associated with lessened or lost power of tactile appreciation. Then the tactile appreciation or the sense of touch can actually be reduced. Now, there is the other way around as well. When we have pain from some part of our body and we touch it or we press it, sometimes that can gate the pain and we can feel better. So then this was a Spanish researcher, and we're talking about 1906. They got a Nobel Prize for this work. Kagel described the consequences of complete and incomplete spinal nerve transection. This is the most important part that I want us to look at. So let me just go to this diagram. Imagine that this is a nerve. This area is the nerve coming down. And then this is the other part of the nerve. And here the nerve got cut. The nerve got injured because of a surgical procedure, because of a fracture of the bone that also cut the nerve nearby, or because of other injuries. The nerve got transected here. Important thing to note. Now remember, this is 1906 when they're talking about it. Important thing to note is that when our nerves become injured, and I'm talking about a bundle of nerves, not one neuron, although one neuron does this as well. When a nerve becomes injured, it starts sprouting and starts trying to find connection for it. So if I can draw this, I'm just going to give an example for, let's say, one neuron. So let's say this is a neuron, and this is their axon. And let's say that this neuron is severed here. Usually what happens is that, is it going to recover, reconnect or not? There are many factors. For example, what is the distance between them, how cleanly the nerve got severed versus how aberrantly it got severed. However, when the nerve gets transected, it is possible that the neuron would start sprouting. That means it would start giving off branches. These branches would go in all kind of directions to try to find a partner to connect with. In this process, they can end up incorrectly connecting with other neurons. I'm going to make up an example just to illustrate the point that imagine this was a pain nerve, got transected here, started sprouting, and nearby there was a other neuron going which was for touch. And imagine this guy got connected here. So now the touch nerves impulses are going through the pain, right? I'm just over exaggerating to explain a point that this sprouting can cause issues and we cannot fix this. We cannot go in and tell this neuron that, hey, don't have these sprouts, cut them all and just connect with the next one. Now, sprouting doesn't happen like this in everyone. Some people get it, some people don't. And some people get it after some sort of injuries and some don't. Some surgical procedures cause in some people for the sprouting to occur. Some don't. For example, amputation of a limb may cause the neuroma formation. So imagine that there is a person whose arm is amputated. And now there is a nerve over here which started sprouting and a neuroma is formed. This neuroma will continuously produce, not continuously, but will easily produce sensations or signals that will be perceived as paresthesias and pain. And sometimes they actually can surgically remove this neuroma, thinking this would help. But what happens is now they have just transected the nerve a little bit above, and then the nerve starts sprouting again, and neuroma's management becomes a little temporary. Similarly, sometimes doctors do a blockade of the nerve, and even that blockade becomes temporary because the neurons would start sprouting and start becoming connected again. Sometimes those connections can become incorrect connections. Actually, I would say most of the time the connections are incorrect because the only correct connection is to connect back to their own next part, which usually this part here, the distal part, this usually, if it is not immediately able to start getting nourishment again, because the nourishment flows to the nerve ends from the cell body. So cell body does all the metabolisms and creates ATP, and then it sends the ATP down the road. And if there is a transection, the nerve, this part will still get ATP, but this part will not. The distal part will not. And because it will not get the ATP, it would start dying. So there may not be actually a distal part to connect back to because that part may have just died, right? So when the nerve is transected, we say that there is a retrograde degeneration, that is the proximal parts start dying, and there is an orthograde degeneration, that is distal parts start dying. These are, I think, Wallerian and Mullerian degenerations as well. But anyways, retrograde and orthograde degenerations can occur. So there may not be actually a distal part. That is what you're seeing here in this diagram, that they have cut. So this is a bundle of many neurons that was just continuing, and they cut that over here. And now you can see this jumble of nerves. These are actually sprouts, small branches coming out of the proximal parts that are trying to find connections. And in that process, look where they're going. They're going upwards. They're making connections with the tissue. They're making connections with the other neurons. They're making connections here incorrectly in the distal parts. And now it's a mess. This mess cannot be corrected easily. Maybe we'll have technologies in the future, for example, maybe just resect this part and bring the other two parts so close together that they can easily start fusing and merging. Maybe that would help. But we are talking 1906 when they discovered this. So I want to read a little more about Cagel's work. Cagel described the consequences of complete and incomplete spinal nerve transection. He elaborated on this in his Nobel lecture, The Structure and Connections of Neurons. Cagel emphasized here that the neuron doctrine, which states that neurons are individual cells with dendrites and axons, and that these cells function independently of each other with gaps between them. So Cagel in 1906 or even before that, he said neurons are cells with the dendrites and axons, and then these cells can actually have connections with each other through a chemical gap, which is the correct structure, which we know today. This is a synapse, this is a neuron, it has dendrites, it has axons, and this the chemical from where various neurotransmitters go from one side to the other. However, you might know Golgi as well, who, the Golgi apparatus is named after him. So there was another scientist at that time, Camillo Golgi. So Kagel used the silver nitrate stain developed by Camillo Golgi to document that nerve cells are in contiguity, while Golgi believed that the nervous system more acts as a reticular system. So Golgi said the neurons are really, so let's say there is a nerve fiber, here is a neuron, then it just becomes continuous with another neuron, then this becomes continuous with another neuron, this becomes continuous with one more, this becomes... So they're just kind of connected. There is no gaps between them. They're not individual cells here, and they're just like a big spider web in our brain and spinal cord. They're just all connected with each other. So in the 1906 Nobel Prize, they both were given the prize. And this is funny that they went to Stockholm to receive the prize and deliver the lecture. Golgi gave his Nobel lecture first, defending his hypothesis of reticular neural networks, which was strongly opposed by Kagel. Among Kagel's many groundbreaking results, he demonstrated the consequences when nerve was transected. Why am I talking about this history? I'm talking about it that even today, when our nerves get damaged, these kind of situations occur. Of course, I mean, it's not that in the ancient time our bodies were structuring and behaving differently. It's the same behavior. It's just it was found then, and it was correctly found. So it is possible that today, when a nerve is damaged, in some people, that nerve would start sprouting. Interestingly, not everyone develops neuromas, for example. And if it starts sprouting, it can make incorrect connections, which can cause a permanent, whatever wrong connections are formed, based on those connections, a permanent problem. Now, one more area, this is one more piece of talk, and then we stop. So Henry Head, a neurologist in London, was interested in the functional consequences of nerve injuries. In a remarkable study, Rivers and Head, so Rivers was a surgeon, Henry Head was a neurologist. Rivers and Head described the findings following injury to two cutaneous nerves done by the surgeon, Mr. Dean, on Henry Head's forearm. So Henry went to Mr. Dean and said, "Can you cut two nerves in my forearm? And then we will observe those nerves and see how are they healing, and are they correctly healing, or are they now misfiring and misconnected? What is going to happen?" They wanted to see that. So Henry offered his own cutaneous nerves. Cutaneous nerves are the nerves that are supplying the skin. He offered them because then they could touch the skin or change the temperature, and they could, write down what the feeling or the senses are. So in a remarkable study, Rivers and Head described the findings following injury to two cutaneous nerves done by the surgeon, Mr. Dean, on Henry Head's own forearm. The sensory findings were followed meticulously over the following 4 years, with almost weekly examination of sensory changes on Head's forearm for various types of sensory stimuli. So 4 years, they kept documenting almost every week for various senses in the area of the damaged nerve and how are these perceived. The findings were described by Rivers and Head in 1908 in a monumental paper of 127 published pages in Brain. And at that time, they classified the sensory system, not pain system, sensory system, into two. They said epicritic system refers to precise, well-localized touch and discriminatory thermal sense, and protopathic system, poorly localized and painful sensation. This is today we say large fiber and small fiber. Large fiber senses, for example, touch, pressure, deep pressure, vibration, proprioception, these are large diameter nerve fibers and they go very fast. And the pain and temperature, these are small diameter nerve fibers. And so because of that, they are kind of dull and more diffused pain. They're less precise. So they call them epicritic and protopathic at that time. Of course, now we have changed that. The epicritic and protopathic systems would correspond to large and small fiber functions. Rivers and Head found that the protopathic system, the pain system, was the first to recover, and that the protopathic sensory system could be modified by epicritic sensations. What they're saying is that the touch, pressure, vibration, two-point discriminations, these can actually gate the pain. And we know that today, that if you have pain somewhere, you try to press on it, and that is a tactile sensation, which then gates the pain in the spinal cord. not only in the spinal cord, in the dorsal root ganglion as well. Very few people know this part. I'm sure that all the neurologists know this, so they not very few, but very few non-neurologists. These findings were the first indication of the gate control theory, which was later to be presented by Malzahn and Wall. And so then they talked about synapses. Then they talk about the dorsal horn. I discussed that last time. So this is a very important part to consider, especially those who have neurogenic pain or neuropathies. Although the pattern theory laid out by the gate control theory is now considered too simplistic, it raised the important issue that destroying nerve fibers or other peripheral or central nerves areas involved in processing pain is probably not a way to cure pain, but may in fact be a paradoxical reason itself for pain. Wolf found that also central mechanisms contributed to hypersensitivity seen after peripheral injury. Then there were more doctors, for example, Bennett and Shih, who found the functional changes after induction of mononeuropathy to the sciatic nerve. So these are the researchers who are working on the peripheral pain. Then there were researchers, for example, Drbeen and Egger in 1903, who looked at damage in the central nervous system and the perception of pain starting after that. Meaning, it's not necessary that there has to be a damage in the peripheral tissues to perceive pain in some part. It is actually possible that the damage is in the central nervous system, which is then projected to a painful stimulus or perception somewhere in the peripheral.